guidelines, beta-lactam or vancomycin plus gentamicin 3 milligrams per kilogram a day. And based on how the adjunctive agent was studied across different organisms and their indications, there are varying recommendations in how we administer the 3 milligrams per kilogram per day. So I just placed that here. You will note that for enterococci, the recommendation is if we're using a gentamicin adjunctively to administer it over the full 4 to 6 week course of therapy. What are some concerns that we might have about this? Well, for one, therapeutic drug monitoring. So if a patient's leaving the hospital and not going to be there while they're receiving gentamicin, it can be sometimes difficult to coordinate therapeutic drug monitoring and peak and trough levels for gentamicin in the outpatient setting. Additionally, the concern for adverse effects. So more so, I would say at a dose of 3 milligrams per kilo of gentamicin, nephrotoxicity, but also over time, longer periods of administration, and at higher peaks, there is a risk of ototoxicity. How does gram-positive synergy work in treating these infections caused by things like strep and staph species, enterococci? This is a good illustration that kind of replaces the antibiotics with different terms that you might use for a football team. Not as timely as it would have been last month if we would have talked about this during the Super Bowl month. But in here you can see that gentamicin works within a cell itself. So generally speaking, gram-positive organisms, specifically those that we're talking about when using gentamicin for gram-positive endocarditis, possess a very thick peptidoglycan cell wall that prevents gentamicin from entering the cell and acting on its ribosomal target area. That's why we have to use things like beta-lactams or vancomycin, both cell wall inhibitors, albeit by different mechanisms, to allow gentamicin in and reach its target area. So essentially, we're getting bacterial death by two different mechanisms here, both by punching holes in a cell wall and also by inhibiting protein synthesis at the 30S ribosomal subunit inside the cell. In 2022, a meta-analysis was published by Ryder and colleagues that kind of looked at this recommendation in addition to 4 different studies, first about gentamicin, and then we'll talk subsequently about rifampin, that looked at the overall results of all 3 of these combined and found that adding gentamicin did not reduce clinical failure in staphylococcal prosthetic valve endocarditis. And that led the authors to believe that recommendations for gentamicin in this specific indication should be downgraded and not necessarily recommended adjunctively for all patients. So this is a little bit of a change from what's traditionally been recommended in guideline therapy, but just curious if the group had any thoughts or any approach that they typically use for using synergistic aminoglycoside therapy in gram-positive infective endocarditis. I'd be interested to see what you all have either by unmuting or in the chat. Thought it would be a good area for discussion.
Hi, Drew. This is Arif. I think my approach over time has changed to use it less for strep, viridin strep, or Staph aureus, and use it mainly in the setting of enterococci. And even there, the question is whether you want to use, the ampicillin ceftriaxone combination, or do you do the penicillin or ampicillin plus gentamicin. But I think I've kind of gravitated to just the enterococci where I would consider it.
Okay, yeah, that's interesting, and Dr. Sawari makes a good point. When we typically have these cases, at least in our practice, I find a lot of the times we're using dual beta-lactam therapy for E. faecalis, ampicillin, and ceftriaxone, like you had mentioned. and really shying away from, in that specific indication, there's a guideline directed regimen of vancomycin and gentamicin, which has the potential to be quite nephrotoxic to a patient. Thank you.
For me, if it's native versus prosthetic, I agree with the native mainly for the enterococcus, but prosthetic, I typically, if no major drug interactions, try as many box, at least initially.
Okay. Yeah, thank you all again. I did want to talk a little bit about adjunctive rifampin as well. So, pulling from the same guidance document by the IDSA back in 2015, they do have recommendations for adjunctive rifampin use in prosthetic valve endocarditis caused by staphylococci. So, rifampin has inherent activity against staph species and does a good job penetrating biofilm that's created by a number of different gram-positive organisms. So you'll find that they recommend either for MSSA or MRSA, considering things like napsilin, oxacillin, and cefazolin, or vancomycin plus rifampin. They specifically recommend thrice daily rifampin, but I've seen used both 300 milligrams twice a day and 3 times a day for infective endocarditis. The concerns with this agent, probably at the top of the list, are going to be drug interactions. And patients who undergo who undergo valve surgery, they may have an indication for anticoagulation afterward, depending on the kind of valve that they had inserted or repaired or replaced. And quite frankly, another indication possibly for anticoagulation aside from the valve surgery. So rifampin has extensive drug-drug interactions and effects on warfarin and our direct oral anticoagulants like apixaban and rivaroxaban. And it can also cause some hepatotoxicity. So pulling some information from that same study back in 2022, the meta-analysis of those four clinical trials that looked at both gentamicin and rifampin adjunctively in prosthetic valve endocarditis caused by staph species. They found that across all 4 studies, rifampin didn't reduce clinical failure or relapse in staphylococcal prosthetic valve endocarditis, was associated with more hepatotoxicity, nephrotoxicity, and the risk of drug interactions. And that of the patients that were on rifampin amongst those 4 studies, 31% of them had it discontinued prior to their expected end date of discontinuation. So they also suggested that recommendations of rifampin use be downgraded in staph PVE. Looking specifically at one of the studies cited in that meta-analysis, is this by Labat and colleagues, published in 2021, that looked at 180 patients with prosthetic valve endocarditis due to Staph aureus, of which 101 were treated with rifampin. They observed no difference in 1-year mortality or relapse rates, and also interestingly found that rifampin was associated with a longer hospital stay. So kind of similarly to the last question, how do you all typically use adjunctive rifampin in endocarditis? Is it something that's typically on your radar when considering treatment for prosthetic valve staph endocarditis? Do you favor just using vancomycin, cefazolin, daptomycin alone? Are there certain patient characteristics that may preclude you to use or not use rifampin adjunctively? If not, no worries. I'm sure there's some variability in practice for sure across the group that's listening here. But I think it's interesting that this newer data suggests that we don't always consider, or we're not as readily considering rifampin, maybe as had been the case 10 years ago now when those guidelines were published. The last thing I briefly wanted to touch on was a really a key component that our cases are going to illustrate is the use of oral antimicrobial therapy for infective endocarditis. Really, in the guidelines published back in 2015 by the IDSA, aside from adjunctive rifampin, ciprofloxacin as a double agent covering in gram-negative endocarditis and linezolid, certain cases of intracoccal endocarditis, they don't really address the use of oral therapy. However, from what we know, many patients probably would prefer oral therapy where applicable and possible to use because it negates the need for long-term IV access and reduces the risk of line-associated issues when someone does have IV access placed. So,
There was a comment put in the chat. It was from Dr. Sarari, and they said that we tend to use rifampin BID for prosthetic valve endocarditis with staph aureus.
Yeah, that's interesting to note because, like I'd said in my practice and in observing other practitioners prescribing habits, I've seen both twice daily and thrice daily used pretty routinely. I can't say that I typically land on one side of the fence or the other, whether or not twice or three times a daily is more appropriate. Given what I just talked about with the suggestion that we may not need to use it as readily as we had thought in the past, I would be more than comfortable using twice daily rifampin in these cases. Thanks for pointing that out, Kelly. Back to the PROET trial briefly. So I'm sure in previous sessions, if you joined this, you've heard several of us probably mention this, but this was a randomized controlled trial that looked at transition to oral therapy after 10 days of IV therapy lead-in. 27% of the patients they looked at were caused or had a prosthetic valve, and the composite outcome, looking at negative outcomes in this case, didn't occur in a statistically significant different percentage of patients in the IV and early switch to oral arms. This is a good description of kind of where in pretty much all cases, there wasn't really an observed difference, whether a patient had a certain background comorbidity or different type of valve, a specific valve infected or organism that was causing the infection. And so we see in the European Infective Endocarditis Guidelines published in 2023 that they recommend clinically stable patients can go home with IV or oral regimens for up to 6 weeks after achieving clinical stability and provide this kind of guidance figure within their guidelines that suggests either 10 days after initiating IV or initiating antimicrobial treatment or 7 days after surgery, we can consider oral antibiotic therapy in patients who are stable with infective endocarditis. So happy to take any questions about anything I presented today or appreciate any discussion that anyone might have to share on this topic if you have some before getting into patient cases. But like I said, thank you again.
If I remember correctly, the European guidelines recommended multiple PO antibiotics, but that obviously wasn't in the POET trial, right? It was more like linezolid or single therapy.
That's a good point, Jacob. In the POET trial, a number, I'm pretty sure all the regimens they used, which isn't found in the main text of the manuscript, but in the supplemental material, they used 2 agents that had antimicrobial activity against the organism they were targeting, which is not what we have done historically here in most cases on COPAT. We've had good success in treating with monotherapy in many instances in these scenarios.
Thank you for presenting this topic. I think one way that I approach or think about endocarditis, it's really a question of source control. The vegetation on the valves is very difficult to penetrate with our antimicrobials. It doesn't, I mean, our antimicrobials are in the systemic circulation, right? So if you have good circulatory system or blood flow to a limb where you're trying to treat an infection, that makes sense. When you have avascular vegetation on a valve, delivering antibiotics to that avascular vegetation is very challenging. So that's why we tend to have this principle of a very high antibiotic concentration or a level above the MIC of the bug, at least 10 to 15 times higher. And if you have source control, say whether that is surgical source control, valve resection, removal of the vegetation, whatever the mechanism of the source control, there isn't a lot of residual microbe left. And from a pathophysiology or a pathobiology perspective, I've always wondered why we are anchored to this idea of it has to be IV for a very, very long time. I mean, the analogy I will take is a diabetic foot infection with the BKA. Once you have adequate source control, where is this rationale coming from? So I think we might see literature shift over time to a little more aggressive. Once you have good source control, transition to oral may be a valid option in a lot of these patients.
All right, do we have any more feedback we would like to share? All right, well, thank you, Drew, for presenting for us today. We appreciate you taking the time and sharing with the group.